So what I'm going to talk about is my experience, which is a 13-year experience, working actually with Chris Denton, who's kindly in the audience, who refers the majority of my patients to me. Just in regards to scleroderma, as you all know, surgeons historically did not want to treat this patient group, mainly because of issues around poor wounding or perceived poor wounding, healing, their complex history, difficult airways. Which I haven't found to be an impediment in regards to treating people with scleroderma. And once you work with a team, the anaesthetist and myself, who are very familiar with it, it actually is really quite straightforward. The interventions I do are usually short, so they're not very long. They're usually under general anaesthetic. I'm just going to talk about those three top elements, which are the things that we're talking about today, the work we've been doing on Raynaud's phenomena, work around linear or localized scleroderma, and then in systemic sclerosis, mainly around the face. So treatments of Raynaud's phenomena. When we started doing this, I was treating people for hyperhidrosis, which is excessive sweating in both the palm and in the axilla. And we would inject the Botox into the hand and it would stop sweating. There was a few case reports of people saying while they were treating somebody for sweating who also had Raynaud's, that the Raynaud's seems to have disappeared. And so on the basis of that, we decided to set up a study to do this. And so we did in 20 patients, and we did initial hand and a Raynaud's assessment both at the before treatment and at 8 to 12 weeks. And we looked at pain, appearance, cold intolerance, pinch and power grip, range of motion, and a score system called a DASH score system, which is used for hand rehabilitation. The injection methodology I used at that stage was through the palm of the hand, aiming towards the vessels that run up into the hand, which is where the vasospasm is supposed to occur, and the idea being is that the Botox targets that vasospasm to inject it towards a digital artery, and little small aliquots of Botox all the way along the hands. What we found was in these patient groups, 80% had improvement in their symptoms, 65 improvement in cold intolerance, 65 improved power grip, and 90% in pinch grip. And interesting, in the hand recovery, what most patients reported is that their grip improved, but also the edema disappeared. And that actually may have been one of the contributing factors to the decrease in the ability of power and pinch and the hand function. We then performed another study, and this was really after discussing with Chris Denton and also seeing the patients. I tried to aim this towards an outpatient treatment because I originally started doing this in the patients I was treating their facial problems, same time injecting Botox into the palm of their hand. But doing this in outpatient is a bit uncomfortable. The skin of the palm is a bit thick, so it's actually not so nice to put into. And I actually saw a slide that Chris Denton, he didn't realize it at the time, he was showing me something else, and there was an arteriography of a hand with somebody who had scleroderma. And what I noticed, which I thought was really unusual, is that there's the main artery is the dorsal artery, or it's not the dorsal artery, but the digital artery that runs on the palmar side. But in this arteriography, I saw that the dorsal artery, which is a metacarpal artery, so quite small, was really large in this patient group. And then I sort of said, well, maybe we can go it from the top rather than the bottom. And also because the dorsal of the hand, the skin is thinner, so it's easier to access, it's not as painful to inject. And so then I said, well, that may be a way that we could do this as an outpatient procedure. Now the procedure itself only takes 5 to 10 minutes to do. It's a really quick intervention. So we also then thought about how do we make this less painful. So we looked at EMLA cream, we looked at ice, and then we came up with this sort of really a freeze spray, an ice spray, and that numbs the area enough. And then I injected with a 30 gauge needle, which is the thing you use for Botox in the face anyway. So it's the smallest needle you can get, and so this reduces it even more. So it is really what I would say is it's not a problem in regards to its intervention and can be done as an outpatient. Again, we injected in the aliquots on the back. The other driver for this is in the palmar approach, we found that 2 of the patients developed a transient weakness in 1 or 2 of their fingers, which was related to a Botox effect on one of the small muscles in the hand. So I also thought that a dorsal approach would reduce this because you can't get access to the palmar muscles from a dorsal approach, and I was hoping that that also would not happen. We did this similar assessment that we did in the first study, and what we found again in this study, a significant improvement in both pinch and power grip, so hand function improved. We did it as an outpatient treatment. We found, interestingly, it's occurred, or the onset of its benefits occurred sometimes as early as 10 minutes following the treatment, or it would take as long as 3 weeks to happen. The interesting thing also is the Botox its effect lasted anything from 3 to 9 months if it worked in patients. Again, really pretty good. The patients that originally started doing it on are the patients that were intolerant to iloprost or allergic to iloprost, but then they did lots of other patients who were on iloprost, and it seemed to have an additive effect and it works even when iloprost is being infused. In fact, I've gone up with Rebecca Canny, who's the nurse that works with me, 2 people in the funny room that they have where they get all this iloprost stuff, and I inject them in the room while they're having their iloprost, and it still seems to help. And obviously, this is a much easier intervention than an iloprost intervention. So what we found is in this study, improvement in symptoms in 86% of patients, were actually slightly better than the previous approach. Reduced swelling and pain, 73% improvement in cold intolerance, significant improvement in hand function, and a significant decrease in Raynaud's attacks. So again, a fairly effective treatment. Interestingly, through this, working with Kevin Howell, who runs the thermography, he's an amazing guy, I was always amazed that when you look at the hand, it doesn't necessarily always show you that you've got Raynaud's going on, but thermography, when you do it, is really quite interesting. And so this is a series of pictures under thermography of this hand after we inject it. So you can see this is blue to begin with, and you can see it's sort of creeping back. This is after injection. See little red spots where the injection sites were, that's obviously hotting up. And as you it keeps coming down, and then that's the end point. And then subsequent patients, you can see this is before intervention, this is after intervention, before intervention, after intervention. So if it works, it really does work. We also treat feet, and it does work in feet too. So some patients have also, as we talked about earlier, is Raynaud's affecting other areas of the body, and we've just written that up too. Now this is the other area of work I do is around facial scleroderma. I use techniques that I use for all other types of reconstructive surgery, which are skin grafts, mucosal grafts, where I take grafts from inside the mouth, skin flaps, either from the face or elsewhere, and then a technique called lipotransfer, where I take fat from usually the abdomen, but it can be from anywhere else in the body, and then transfer it after centrifuging it into another region of the body to restore volume. So I'll just talk about that work. So we take fat usually from the abdomen through a small little incision in the belly button with a small needle, as you can see there, and then retrieve the fat in these little in 10 ml syringes, which we then centrifuge to centrifuge it down. So it separates. This is like before centrifugation, and this is after centrifugation. So you can see that this is actually free fat. So, and this is what's called SVF, or this is the fraction that has the fat stem cells within it, and below that you can see is blood. So that's the bit you can use to transfer as fat. Now I also, a piece of research we've done where I've shown that this part of the fat has got more stem cells in it than that part of the fat, so I actually only use that part of the fat harvest and I discard that. So what I've done with centrifugation is actually enriched the number of stem cells that are within the fat. So you get the benefits of stem cells. As I kill myself. Transferring the fat into smaller little syringes, 1 ml syringes, and then injecting with small needles. So it's a truly minimally invasive technique. It doesn't require big surgery, big incisions. It's done really with small needles. And also I do it with 1 ml syringes so that I can really concentrate on the aesthetics. So it's really small volumes, trying to improve really the aesthetic as well as the functional outcome. The idea is you lay the fat into layers. The idea of laying it into layers is that it has to be revascularized. Because it's been detached from its blood supply, it has to re-establish it. And it re-establishes by blood vessels growing in those little grafts. And so they have to be of a small enough size also for the fat to be revascularized. Historically, they used to use very big pieces of fat to transfer around, but it never really worked very well. And this technique, that's why this technique has become so popularized, because they found the small size is revascularized and predictably revascularized. This is an example of a patient with lipodystrophy where I try to document, so I've set this camera up more than 10 years ago, where I document the volumetric changes using a three-dimensional camera system where I can subtract one image from the other and work out the volumes that I've put. Not only do I know the volumes I put in, I know the volumes that remain after it's healed. And this is a patient, as you can see, pre and post treatment. On the left side, this again is the facial lipoatrophy. The left side is pre-treatment, and right side is after treatment. Now she's had 2 to 3 treatments to get to that point. It's not just one treatment. And this is the experience I've had in the scleroderma. So just about localized scleroderma, the coup de sab, and you can see on the left side a classic coup de sab, and this is after filling on the right. You have to do it a number of times to get it right. This is another patient that Chris and I know very well. On the left side of her cheek, she has a fill defect here. You can see, but the skin, when we first started doing it, this skin was down to bone. So there was very little tissue there. And when I first met her, she really was becoming socially isolated. She found it very difficult to go out in public. She found people stared at her, so she had a real problem related to it. So I work very closely with clinical psychologists, which we have in the department, to work on the psychological aspects of it. But you can see on the right side there, this is her post-treatment, and again restoring volume, and it looks pretty good. So it's actually pretty good endpoint, but it required a number of interventions to get there. This volumetric replacement is really what fat transfer was designed for, but there was something about the fat volume replacement that we found in the patients with systemic sclerosis which led us in a slightly different direction. So these patients are exactly the same. We've seen this sort of appearance before, and if you look at this is again an old patient of both Chris and I's. If you look at her face, this illustrates very clearly the changes that occur in facial scleroderma. What I usually have to do is get patients to bring photographs of how they were so that we can see the changes that have occurred. And sometimes I have to point out the things that I predictably can see. So if I look at going downwards, it always affects really below the eyes down. It can sometimes affect the forehead. But you get a lid retraction, so it's down, flattening of or hyperplasia of the malar eminence, that's through the lipoatrophy in that area, nasal dorsal skin thinning, pinching of the nose here, loss of alar volume, and also loss of the nasal dome. So the alar cartilages sit like that, and they become exposed. So you really have to try and address all of that. Then you get upper lip changes, lower lip changes with lip retraction, and obviously volume loss here. Now she had, unfortunately, when I first saw her, she had a previous surgery by a maxillofacial surgeon who tried to do some surgery, and he split her lip. So she not only had this lip split, which was repaired, you can see the notch there, she also had no sulcus. In other words, she had no, or very little sulcus, so there was no space between the lip and the gums, so that when saliva pooled here, it dribbled out through the mouth. So she had real problems with that. And so obviously the surgery we tried to do with her was to address that, and I'll come back to her at the end. So this is the results of a patient group which we're about to publish, and myself and Chris will talk about it at lunchtime, so we'll eventually get there. So this is a patient group of 62 patients, both with diffuse and limited cutaneous systemic sclerosis, where we looked at mouth function as the primary outcome, which we thought was the most important, and the secondary outcomes was related to quality of life and also volumetric changes. What we found was also the question we were interested in is, would immunosuppression make any difference in regards to patient outcome? In other words, if you were on immunosuppression or not. And historically, immunosuppression is supposed to delay wound healing. Maybe it impacts it in a negative way, but we found it made no difference at all. And interestingly for me was when I started treating these patients 13 years ago, everyone was extremely nervous. We used to stop all the medication. but I found it quite problematic for the patient because they were on so many medications. And so in the end, I decided we wouldn't stop the medication, and we sort of treated them while on medication, and we found no difference. So in the end, I don't stop any medications, and I keep going. We also found in this outcome measure that it didn't really matter whether you were diffuse cutaneous or limited cutaneous in regards to the outcome. It also didn't make a difference. You still had a good outcome. We found that there was a significant improvement in this patient group in mouth function, and also interestingly, if you repeated the treatment, which is what we do a sequence of treatments, it also is additive. It improves every time we do it, so it keeps going. And so patients on average get between 3 and 5 treatments. Sometimes then when they finish that treatment, it's usually they determine it between me and them, we're talking about it, they stop, and then they come back in 3 or 4 years. Some patients now come back, and we then repeat the treatment. And I try to compare or say to the patients, it's really like chasing a slow-moving bus. It's sort of, I catch up with you a little bit each time. The other thing which we found very interesting, and this is the patient's report back to me, is that not only did the mouth opening improve, but also patients had return of saliva. Is that their mouth, their dryness of the mouth disappeared as well. Again, I don't know why, but it seemed to. We found significant improvement in quality of life measures, and also interestingly in volumetric augmentation using that scanning, the 3-dimensional camera. We found that there are different areas of the face that retain fat better. So if you look at the, which is, as a plastic surgeon is really quite interesting. So if I look, for example, at the highest one, which is 93.7% retention, that's in the cheeks. So cheeks retain more. The area that retains least is the lower lip at 27.3. Now this is interesting. I don't know, I mean, we can make a lot of reasons why it happened, but what it has done is it changed my approach in regards to, so the difference between the upper and the lower lip is I actually do less in the upper lip than I do in the lower lip, because I know the retention is going to be more in the upper lip than the lower lip, again to improve the aesthetic endpoint. So this is an example of patients pre and post treatment, pre-treatment at the top, post-treatment at the bottom, with a change in the perioral wrinkling and volumetric changes. This patient's had treatment. As you can see, her incisor show on the top is much more than on the lower part. But the more interesting thing is when we look at it, again, these, you might think that they're not really that obvious, but if you look at the lateral profile, if you follow the lips down here, and you follow the lip down here, and then obviously the incisor show, but also the lip here, it's changed the profile, it's got fuller. So again, these are small incremental steps, so each time you do it, it improves. And it's quite a hostile environment to put fat into. It's fibrotic. It shouldn't really work that well, but it seems to. This is the perioral change. As you can see, the wrinkling pattern, the pre-operatively above and post-operatively below, and the 3-dimensional scan showing volumetric changes. Again, improvement. And the other thing is in this, is again, it's come back to the upper and lower lip, is you can see her upper lip at the moment is half and half, and now it's gone to half and 1/3, 2/3. And actually that's the correct aesthetic endpoint. Or also fissuring has improved around the mouth. The mistake that most people make in cosmetic surgery is that they overcorrect the upper lip. So Angelina Jolie, for example, somebody like that, or who's it, Katie Price? Yeah. So these type of people, if you look at them, they have a sausage upper lip. So their lips are half and half. They look weird. You walk into a room, you say, there's something wrong with them. So that's the sort of end point you should be getting to. It's 1/3, 2/3. And that's I'm obviously pernickety about endpoints, and so I try to make sure this is as aesthetically perfect as I can make it, as well as obviously reconstructively it works as well. So in summary, we've had graft survival was better than expected because obviously of the comorbidities, and when we first started doing it, I didn't know it would work. Decrease in pain and discomfort, significant improvements in oral function, significant improvements in psychological scores. Dental work was easier, and that's actually, when I first started to realize this, it was the patients that told me about this. It was an unexpected finding. I thought I was going to be replacing volume. The patients then, after I treated them, and they were very brave to do it at the beginning because I didn't know whether it would work or not, or would make things worse, they kept telling me, my dentist says I can now do posterior dental work. And I go, don't know what that. And it took about probably 5 or 6 patients before it dawned on me that actually there was something antifibrotic going on as well. And that's part of the work that myself and Chris are doing now, is to try and understand why. Why it should work? Now, I've treated burn patients, facial burn, scars, radiation-induced fibrosis, again a real problem, lichen sclerosis. Other people have done Dupuytren's disease, scleroderma, and graft-versus-host disease, another fibrotic condition. I've had responses in all these patient groups. So actually something interesting is going on from an antifibrotic point of view, but we don't know why. So part of the research we're undertaking as a unit is to try and tease this out. Why it might work? People might think it's a mechanical effect, that the fat sort of has a padding effect between it, or a paracrine effect is another way, that it might secrete stuff that actually causes things to remodel. We still don't know. There's definitely a relationship with what we think is the adipose-derived stem cells, and these are the stem cells within the fat, and it's actually in everyone's fat, and actually there's quite a reasonable volume. Even as you get old, that fat stem cell volume is still there. This is the work we did originally, where we centrifuged and looked at that there was a higher stem cell concentration in the lower part than the upper part, and so we used the lower part. We also looked at the performance, or how these stem cells behave, and we found there was a difference between scleroderma fat stem cells and age-matched controls. So, but we still found that they did something. They differentiated, so they were effective, but they weren't as effective, but they still did something. We also did some work where we put the stem cells from scleroderma patients, fat stem cells, with fibroblasts from people with scleroderma. And we found, interestingly, that these fat stem cells caused the fibrotic genes to be turned off. Again, really interesting. So we don't know why. We don't know if that's the only thing that's causing this problem. But again, you can see it hints towards a potential therapy beyond just what we're doing in the face. That you could purify this element, you could find out what the cell is, or maybe the molecule or whatever, and you could have a new therapy. And this is the last patient, which was the first patient I talked about, where I used lots of different techniques to effect a change. And this is her when I talked about before. You can see the lower lip with a little notch, and you can see from the side exposure, hyperplastic, flattened cheeks, retracted lower eyelid, pinched nose. I did a massive release, soft tissue release, to recreate her sulcus, maintaining the nerves. Those little yellow things are the inferior dental nerve that supplies sensation to the lower lip, preserving those, and then inlaying a very large graft. I then, in another operation, took a graft from the thigh, inside the thigh, called a fascia lata, which is sort of like a fibrous piece of tissue, again to suspend the lip off the cheekbones, as well as fat transferring both to grafting to the cheeks, but also the nose. This is her following that intervention, showing, you can see the lip has been pulled up, and they're the little incisions, and interestingly, they heal really well. And this is her afterwards, and if you look at it, you go, well, maybe it's not that exciting. But if you look at, that's a pre-surgery, this is a post-surgery. So if you look at her lid has come up, her hyperplastic malar, or cheek, has filled. Her nose is improved. The alar volume, although you might not see it, it's actually changed. The upper lip has changed. The lower lip is in a much better position and forward. She's still what we call retrognathic, which is where her jawbone is a bit too short, and that's the reason she got the split in the first place, because a maxillofacial surgeon was trying to bring it across. But I've also augmented her chin with an alloplastic material. And this is her from the side, again showing a similar result. And you can see that she's ecstatic in regards to her appearance, because she walks down the street, no one bothers her. Most people want to walk down the street and no one look at you, just want to blend in, normal. So where now? We're about to do a Raynaud's trial, again to look at a new a different approach. We've also got a fat stem cell enriched lipotransfer trial, which the SRUK have helped with some funding, and we've applied to the NIHR. We also, in the part of that, we'll try and find out the mechanism of how it works, which might lead to an isolation and treatment of other tissues and organs with this intervention. And this is a thank you to my patients. Lynn being one of them, but many others who've taught me a lot in this. First of all, to be brave, because they're quite brave. They actually took on this work at the same time as me, so it was a partnership. And I thank them for, first of all, allowing me to operate on them and get to know them, but also for their bravery in allowing me to do it in the first place. So thank you.
Hi, hello everyone. My name is Lynn, and this is me in 2001. Yeah, that's me. I was at the prime of my life, a businesswoman, part-time model, and considered by others to be entrepreneurial. Then suddenly, my life changed dramatically. I was diagnosed with severe diffuse scleroderma. Scleroderma can turn a person into stone as it attacks its own connective tissue, causing it to harden. It is a disfiguring and debilitating disease. Then, as this started to happen to me, I began to not recognize myself anymore. The Lynn I knew was starting to disappear. I found the effects of my facial features and hands devastating and started to actually isolate myself, and as I became embarrassed, worthless and depressed. But the one thing I did continue was going to my hospital appointments at the Royal Free Hospital with Professor Chris Denton. And thank God I did. Why? Because I'd heard about exciting new stem cells treatments led by Professor Peter Butler. At my first appointment with Peter Butler, he explained he would extract fat from my stomach. I thought, yay, get some of that fat. But he was going to remove the stem cells and transfer them into my mouth, nose and hands. I finally had a glimpse of hope, and hope is a wonderful thing. So after agreeing and going for my first stem cell transfer, well, naturally I was bruised. Of course I was. It's an operation. Who's not going to bruise? But it was only for a week or so. But let me tell you, it was also worthwhile because I actually started to feel movement in my mouth, and my jaw just felt really less painful. Finally, my reinvigorating journey had actually begun. After the many years and seeing improvements over my face from the treatments, Professor Butler decided to try stem cells in an ongoing wrist ulcer that I've had for 6 years, which didn't heal, caused by calcinosis. We did a few months ago, and I'm happy to report it's finally beginning to heal over. So this stuff works. It has to. This is me in 2017. Anyway, I no longer have to hide, and I now actually feel part of society. My confidence has grown, and I can actually smile again. My quality of life has improved. I have less pain in my jaw, and I can actually eat comfortably now. And visiting the dentist is no longer a traumatic experience because she can now manage to actually work in the back of my teeth. So now she's happy to see me. Before she's, oh no, you again. And as you can hear, I can talk well, which I'm not sure my husband is happy to hear or think it's a good idea. Always tells me I talk too much. But anyway, giving back to others and sharing my story has actually given me a sense of self-worth and purpose, and contributing back to society. I'm actually working with Professor Chris Denton and Professor Butler as a patient representative, and have formed a scleroderma stem cell focus group on Facebook for other patients. So look for me and add me because it's going for a good cause. This is who I am today. My book is proof you can still do it. Yes, I have written and published a novel called Prize Winner, and you're all invited to my book launch at the Royal Free Hospital on Monday the 9th of October at 5:30. The book launch will feature actor and author Simon Callow. He's going to be reading extracts from my novel. You're all invited. Please do come along. And finally, on a last note, I cannot leave you without drawing your attention to other scleroderma patients who are not as fortunate as I am. The hope for the future lies in stem cell research, which will benefit all of us. And for this reason, I'm donating a portion of the sales of the profits of my book to prize winner to scleroderma research and the Charles Walton Centre for Reconstructive Surgery. So come and buy my book and support a good cause. Thank you.